mean, I'd round with doctors in the hospital, and before we go into a person, they'd be like, this person has fibromyalgia, and they roll their eyes, and the med students would snicker, and like the other residents would kind of laugh, and we'd go in there. It meant like whiny, weak person is kind of what is that's how the medical world views someone with fibromyalgia. Doctors basically treating these patients with fibromyalgia are saying you're not going to get better, and so they almost kind of like contribute to some of the agony with it, because a lot of it is the lack of hope that these people, it's just not a lot of hope for these people, and day in, day out, you're dealing with this as best you can. Ketamine, treatment did a lot.
Okay, Dr. Johnson, today is February 13th, 2012, and we need to note that this is after your 4th infusion. Now we're 2 days after all that. So the last infusion was on Friday, today is Monday, and we just went over your pain thresholds over here, and I think you'll agree with me, there was a dramatic improvement in your pain thresholds in your upper and lower extremities, and that's an objective measurement, okay? Also, you reported to me that for the first time in approximately a year, you were able to overcome the urinary retention. You had a few episodes where you were able, for the first time, to void without the urinary retention. Is that correct?
Voluntarily. Voluntarily initiate, yeah.
Okay, voluntarily initiate, right. And how big of a deal is that?
It's huge.
It's huge, right. And let's...
That would be a game changer if I could get that back.
Right.
That would change my quality of life, like orders of magnitude.
So why don't you tell us why it is such a handicap to have urinary retention in your particular situation, if you don't mind?
Because it basically limits your ability to do things. Like, for instance, let's say you have, for me, I can only urinate in my house, and I have to go through basically meditate before I'm able to urinate. I have to get to a point of complete equanimity and peace, and then I have to distract my mind by reading something. So it's a lot of work, and so it really curtails what you can do as far as going to a park with my child for that's across town. I have to think about I gotta wait until I void and then do that. It kind of becomes this, if we want to go out and we're going to a dinner party, if I'm not able to urinate sometimes, we have to cancel those plans, and then once I urinate, we'll go out with ourselves, but we'll miss our friends.
And what we're talking about here is what we call straight catheterization, correct?
And well, I don't have to straight cath most of the time. Straight cath, for 5 months I straight cathed continuously without any voiding at all on my own. But then by applying an electrical stimulus to my abdomen, it's able to somehow initiate the voiding process. I have to do that a couple times a week, and I'm able to void with that. If I meditate, I gotta get to a certain state to do that, and sometimes I can do it in public and sometimes I can't.
Right.
And it's that unknown that makes just doing regular things like going to the grocery store and then going to the fish market a little bit difficult.
Sure, I understand. Okay, now the next thing we want to do here is we want to get into your functional testing. You ready for that?
Yeah.
Okay, first thing we want to do the vertical finger test. Look straight ahead. Put 2 vertical fingers in your mouth, please. Are you having any pain when you do that? Okay, you didn't have any pain when we started, and you don't have pain now, okay?
Right.
Next thing we want you to do is take that right hand and put it behind your head. Remember, you had some pain in your shoulder area before we started. Do you still have that pain there, or is it decreased, or is it more?
It's markedly decreased.
Markedly decreased, okay. Next, I want you to do the left side, please. Put that behind your head. And I don't believe we have pain there when we started, or it was, we did. Do you have pain now?
No.
So that pain has disappeared.
Right.
Okay, take that right hand out in front of you, please.
Yep.
Open and close as fast as you can. What's happened there with regard to the pain in the forearm?
Pain is markedly down.
Markedly down there?
Yeah.
Okay, now do the left side, please. Same thing.
Yeah, there's no pain.
No pain there. Okay, very good. Okay, the next thing we want to do is we want to turn to your lower extremities, and we're going to stop for a minute so you can take off your shoes, okay?
Yep.
Okay, Dr. Johnson, put your feet out in front of you, please. Okay, rotate your right ankle for me, please. Wiggle your toes, please. Okay, and hitchhike back to Chicago. There you go. Okay, do the same thing over there. Rotate your ankle, please. And wiggle your toes. Yeah. So your function is the same there. Now we're going to put you through a little bit bigger test. Why don't you stand in front of the door there, please?
Yeah.
Why don't you take 3 steps forward, please? Okay, very good. And take 3 steps back. Now remember, when you did that before, you had a lot of trochanter pain. Point to where your trochanter is so everybody knows what we're talking, right in there. Okay. And the question is, has that decreased, increased, or no change as far as just simple walking?
Markedly decreased.
Markedly decreased. Okay. Next thing I want you to do is I want you to walk on your toes. Three steps forward, please. Okay, very good. And 3 steps back, please. Okay. Are you doing it on your heels too? Okay, that's fine. That'll work. Now, either on your toes or your heels. Remember, you still had that trochanter pain. You still have that?
Yeah, a little bit in here.
But not like it was before?
No.
Okay,
Better.
very good. Now, go ahead and have a seat, please.
Yeah.
We're going to go over the treatment plan with you.
Okay.
Now, here's what can you hold off on that just for a little bit? Yeah, just for a little bit. Because we're just about done. I'm going to go over the treatment plan with you. Now, we talked about the idea that I expect you to do better without more ketamine, okay? And the key to that is going to be the heated pull exercises. I think we need to keep your weight-bearing exercises to a little bit of a limit right now as far as developing and rehabbing you, okay?
Okay.
We talked about the reasons why the heated pull exercise. One is it's non-weight bearing. Number 2, you still have some, but not a lot, hardly any, this what we call central pain amplification. You still have a little of that left, and that the water is a potent desensitizer. We talked about the water can be a profound way to manage stress, and it can decrease stress, right?
Mm-hmm.
And just for everybody to be educated, is stress good or bad?
It's neutral. It's how you manage it.
That's right, exactly. You hit it right on the nose there. So stress is sometimes essential for our survival, even in the modern age, in terms of keeping us on our toes, right? And on the other hand, it can be destructive. So managing stress is a very important part of managing chronic pain. Now, the next thing we talked about is how you can use the heated pull exercise as a way to gauge whether you need another ketamine infusion, and we talked about exercise tolerance. So let's just say, the first week 15 minutes is your workout, but the next week it's 17 minutes. You're improving on your exercise tolerance as long as the exercise is continuous and you measure it and quantitate it. And we talked about if you get out of the water and you have some soreness or some pain after you get out, is that good or bad?
That's good.
It's good. Yeah, you need a little good hangover to really part of the whole rehab process. On the other hand, if you're laid up for 1, 2, or 3 days, that's what we call a bad hangover. You don't want that. If you have pain during the exercise itself, that's not necessarily bad either. So you got to get into this balancing out the proper level of pain control as it relates to measuring your exercise tolerance. Okay, so I think with the exercise program, I think that I can expect still further improvement in your condition. Okay, we want to treat you, but we don't want to over-treat you. Okay.
Right.
Now the other thing we talked about is the importance of pain control. For acute pain. So if you have to have surgery, if you get injured, you have to control that pain, because that tends to not bode well with patients that have either fibromyalgia or CRPS. Another thing we talked about is that there seems to be a very close relationship between CRPS and fibromyalgia, this so-called central amplification of pain. Early on, we talked about the glutamate levels and so forth and so on. So I think we should try to stick to a protocol which is similar to what we do for the CRPS patients in your case, okay? I know your wife, Dr. Johnson, had to go back to work, so she's not here today. But did she have any questions, you think, or any concerns that she wanted to be addressed?
She's just curious about what we can expect from going forward as far as prognosis goes, and the fact that I have responded so well, but I'm not all the way there.
That's right. And my experience tells me that we've had patients before that have had fibromyalgia, but they also had clear-cut case of CRPS, whereas in your case it's purely a fibromyalgia as far as we can tell. We don't have a lot of, I don't have, and not many people have, studied the results of giving ketamine to patients with fibromyalgia alone. But I anticipate you to continue to improve. The key here is going to be your exercise program, the heated pool exercise that we discussed earlier. Okay? I expect that because, you know, keep in mind now, for the last year at least, you had problems with urinary retention. You found that the ketamine can help with that. You found that your pain thresholds have improved dramatically, and that's an objective measurement of improvement. So I think you should be very optimistic going forward at this time.
Okay.
Any questions?
No.
And what did you think? Was it worth it?
Absolutely.
Yeah, okay.